Alrighty, welcome back everyone. This is chapter 13, Anesthesia and Physical Monitoring. We just got done talking about chapter 12, Pharmacology, and some of the different drugs and things that we use in the operating room, what they're used for, kind of why we combine certain things for that kind of synergist effect, trying to make things last longer, right? Trying to make your local last longer with the addition of epinephrine in it. We talked a little bit about hyper and hypo and isotonic solutions. Remember, you always have to have two solutions that are in comparison to one another. So, but here we're going to be talking about anesthesia itself and kind of the monitorings and things that get done with anesthesia. Anesthesia itself means without sensation. So that's what we're trying to do for these patients is they don't have to feel what we're doing to them at all, right? The job of anesthesia is their ultimate goal is to maintain homeostasis, right? Keep that body in that balanced physiological state, right? And then we can alter their level of consciousness by disrupting neural pathways and things like that. And just kind of like, we can knock them out and numb areas and things like that so they don't have to feel what we're doing. Some important kind of things to understand, are like sensation, analgesia, consciousness, and sensation or sedation. Sensation, this is that awareness of stimuli, right? You can feel things. You can hear, you can see, you can sense. Right, you use your five senses. Analgesia is the loss of pain sensation, not just sensation, pain sensation. That's a key thing to understand because sometimes, like if any of you ladies have ever had a C-section and you had like a spinal or an epidural in, you still feel them working. You feel all the pressures, you feel things getting moved around, all that kind of stuff, but you just don't feel the pain. So that's that analgesia component is no pain. Consciousness, this is where you're able to sense everything and kind of respond to your external environment, right? Sedation is now, you might be kind of awake, you might be kind of asleep, you might be able to respond to stimuli, you're kind of in between, right? You may be like fully out, but if, a little bit of nudging and everything, somebody asks you a question, you can respond. That's that sedation. You're not completely asleep, but you're not completely awake either. You're kind of in the middle. Central nervous system depression, that's another way of saying sedated, right? The central nervous system is kind of your brain, your consciousness. If you're depressing that consciousness, you're kind of sedating the patient. Kind of unconsciousness, that's when you're completely out. But the difference between a coma and unconsciousness is in a coma, you have very little to no brain activity. And then amnesia, obviously, you can't remember what's happened, right? We do have some drugs that we give patients that will cause, like I believe Versed is one of those, where the patient doesn't remember up to 5 minutes before receiving the medication. So a lot of patients don't even remember going to the operating room. They don't remember the trip from pre-op to the actual OR, which means, do you think they're going to remember us? Probably not, unless they come in, without having the Versed. But they're still going to meet us. There's, you'll still introduce yourself. You'll still say hi, all that. And what I'm referring to is that when the nurse wheels into the room with the patient and you were over at your table still doing your setup, you may stop and say, "Oh, hi." Like, "Oh, this over here is, Aaron or AA Ron, he'll be, the tech in the room today, and you just kind of, oh, hi, how's it going? And they're like, oh, hey. Most patients don't remember the people in the room because they had that medication on board when they came in, and when they woke up, they don't even remember going to the OR. So they're definitely not going to remember us. So these are some of the people in um, in and around the anesthesia department. The anesthesia department is kind of a sub-department of the OR, but you have the anesthesia care provider, ACP. The anesthesiologists themselves, an anesthesiologist is a medical doctor. And the reason the difference between an anesthesia care provider and an anesthesiologist is that you can have a CRNA, which is a certified registered nurse anesthetist. Now, you have to go to school to become an RN, right? And you have to get your bachelor's degree. And then you go to a program and learn and become a CRNA. But now you're the one who's up at you're still considered a registered nurse. And there has to be an anesthesiologist that comes and double checks your work and things like that just to make sure. But you're the one who's up intubating the patients, putting them to sleep, monitoring them during the procedure, waking them up, taking them to recovery, all that. You're basically doing the job of an anesthesiologist, but you're not getting, you're getting good pay. Don't get me wrong. You're still getting well into the 6-figure range a year, but you're not making anesthesiologist money because you have RN behind your name, not MD. Then you have like anesthesia assist or anesthesia techs. They're kind of the same. They're the ones who are going to, restock their carts, kind of clean up after them, organize their areas, change out the tubings and stuff that go on the anesthesia machine when they're doing a turnover. They may even assist and help the anesthesiologist intubate the patient. Most often, it's the nurse. But if this is going to be a very difficult intubation, the patient has next to no neck, they're obese, they've had previous neck surgery, you can't really tilt the head back, things like that. They may need a few extra pieces of equipment or certain supplies, things like that. That's where that anesthesia tech or anesthesia assistant is going to come in handy, being able to go and get those things for them and help them hook them up and stuff like that. Your role of your anesthesia care provider is maintaining that homeostasis, right? Monitoring the level of consciousness, right? Did we want this patient completely out? Are they supposed to just be sedated, right? Are they starting to kind of wake up? Usually, what happens when you're just starting to wake up, right? You kind of start to move a little bit more in your sleep and things like that. We're doing surgery on you. So we can't have you, like we're doing surgery on your hand and you're sedated and now you're starting to wake up. You're like, and that hand starts moving, you want to bring it up and kind of rub your eyes and stuff, but we're working on it. So that's where that anesthesia care provider, they see you starting to kind of come around. And part of it is they're watching it on the monitor too. They're seeing that the heart rate might start to go up. There may be a little bit more, movement from the head and things like that. Those are all cues that the patient is starting to wake up. Let me give them a little bit more, or let me ask the surgeon, how much longer do you have? And that can kind of gauge how much more medication I need to give to the patient or not, right? If the doc's like, oh, I'm almost done, I'm putting in my last stitch, they might be like, okay, cool, and not really give the patient anything because that stitch is going to be in, he's going to be tying it off, cut, and then we're going to be cleaning up, putting dressings on. By the time we get all that done, then the patient's awake enough, we can move them over to the gurney and take them straight to recovery. We don't have to wait for them to wake up a little bit more before we take them out of there. Pain management, right? They're giving pain meds to the patient at the end of the surgery and things like that. And if the patient is experiencing pain in recovery, the recovery room nurse calls into the room and they don't typically ask the surgeon what kind of pain meds they want. They'll ask anesthesia. But it could be a conversation at the surgeon because there may be certain pain medications that the surgeon doesn't like. And after working together, for years and things like that, you kind of get to know, things that people like and don't like. And you don't necessarily have to have those conversations all the time. But giving and monitoring the effects of medications given, right? If you give a patient some penicillin and or some Ansef or something like that prior to surgery, and there was no indications of them being allergic or anything like that, but then they show like kind of a blotchiness or something like that, it may be something that needs to get looked into in the future. Definitely maintaining that airway, right? And that was evident when we're moving the patient and positioning patients. We always have to get anesthesia's approval because of that airway issue. We do not want to do anything that compromises that airway because then it compromises the patient. And then also monitoring patient responses, especially in the cases of like a local anesthesia or something like that, or those who have had like the C-sections with the spinal. Before they make the incision, they'll take an instrument, usually like a pair of pickups with teeth. They may even take like an Alice clamp or something like that, and they're going to go and pinch on the skin in random areas in places where it's supposed to be numb, and ask the patient, does this hurt? And anesthesia is because usually the drape is up and you may not be able to see the patient's face. So then anesthesia is there to hear their response and then kind of give it back just in case they're a little out of it or whatever. I talked about anesthesia tech, right? Maintaining that equipment, preparation of drugs. That's bad wording. It's more of restocking of their cart, things like that. Because and anesthesia keeps some of the meds in their carts too. Like your propofol and succinylcholine, the things that they use most often. It's those emergency things that are on the crash cart, but they're restocking that stuff. They're not really preparing. Preparing sounds more like they're drawing things up, and that is not something that a anesthesia tech does. They do not draw up medications. They do not administer medications. So they do like a pre-op eval, right? We talked about this when picking up the patient, right? They have them open their mouth real wide, things like that. They're doing what's called a ASA status. They're looking at all kinds of different risk factors. They're looking at the airway. They're looking at past history, past medical history of the patient, things like that. That is all going to come into play in determining what drugs they're going to use, how they're going to put this patient to sleep, what kind of special equipment do they need, right? The E means for emergency. You can be an ASA 1E. 1 is you're like the ideal patient. You have a nice big open, oral cavity. Have a nice long neck. You're not obese. You don't have a whole lot of tissue and things like that. You don't have any asthma or problems with your airway, those kind of things. When you get up into those ASA 5 ranges, this is like the no neck, barely open your mouth. But then they'll put an E at the end if it's an emergency procedure. So they had to do cricoid pressure or Selleck's maneuver. Those are the same thing. Or they have, they had to do a rapid induction things like that, because the patient was they couldn't be NPO. It was a trauma situation. That's where that E comes in, just to mark it as emergency. It also helps for their reimbursement. So the more difficult the airway, and especially if you put the emergency on it, it already kind of takes it up a notch. But then the more the anesthesiologist gets paid by the insurance company or whatever, because it was a difficult procedure. Like the comorbidities, right? We talked about that. Any other disease processes this patient has going on is going to affect their anesthesia classification. Any current meds or allergies, anesthesia history, that airway status, all of that comes into play in determining that ASA code. Musculoskeletal, your mental status, your cognitive ability, right? Are you with it? Are you thinking, right? Do you have a support group? because all of that plays into, because that's how the patient is going to do even after surgery, is do you have that support group? Are you cognizant enough and with it enough that the education and the things that we tell you before you leave, you're going to understand to be able to follow through on, right? If not, maybe we need to look at putting you maybe, stay overnight at the hospital and then look to put you into like a rehabilitation kind of center first, so that you have some kind of support to watch and help take care of you until you get back to kind of a normal thing like that. And all of it's, these kind of questions, it's these investigations, right? While they're asking these patients these questions and they're gauging their responses for that neurological status, they're looking around the room, seeing the family members that they have, or friends, or whoever's there with them. If nobody's there with them, that becomes a factor too, right? Or do they look, that musculoskeletal assessment is, do you have good range of motion? Do all your joints work? Are you getting good nutrition, right? Do you look what's called cachectic, which means kind of skeleton-like? Are you super thin, or are you morbidly obese, right? All these things come into play when getting that ASA classification. So based on the type of anesthesia that we're going to use, whether it's general, regional, spinal, beer block, local, whatever, is all going to depend on, this patient's ASA classification. How easy is it going to be to intubate this patient? Is it going to be extremely difficult? Then, we may want to look at an alternative form of anesthesia, right? What's their current physical history? What kind of shape are they in, right? Do they have a metabolic disease going on, so that if we're giving them these inhalants and things like that, it may take them longer to metabolize, these certain drugs and things that we're giving them. What's their psychological status? Are they with it? Right? What kind of surgery are we doing? Are we doing something that we have to give them general anesthesia, no matter what their ASA classification is, right? How long is the surgery going to be? Is it a 15-minute surgery? Is it a 4 or 5 hour surgery? Right? 4 or 5 hour surgery, you're looking at definitely general anesthesia, because a lot of those other forms of anesthesia are not going to last long enough. Right? Is there a history of adverse reaction? Do you or someone in your family have a history of malignant hyperthermia? That's going to change what anesthesia and drugs and things that we may choose. In your book, in chapter 13, definitely look at box 13-1. This will go over these different types of anesthesia. Your pre-op checklist, right? This is, did we educate the patient? And in pre-op, that's basically that informed consent, right? Was a conversation had with that patient about what's going to happen, what are the risks and benefits, all of that, right? Did we identify this patient? Name and date of birth, right? Did we check to see that the surgeon came in and marked the correct spot, right? We're doing the correct procedure on the right leg, right leg, right knee. Is the surgeon got his initials on it? That kind of thing. Did we check our paperwork? We've got our, our consents and all our labs and things like that. And then also we want to make sure that if the patient has any kind of resuscitation orders, those could be like a DNR, DNAR, or it could even be do everything you possibly can. Most of the time, you're not going to have a piece of paper in the chart that says do everything you possibly can, because that's already implied if you don't have the do not resuscitate or do not attempt resuscitation. It's already implied that you want to live. So we're checking allergies, right? Because we don't want to accidentally prep them or give them some kind of medication that's going to cause an adverse reaction. Anything that was given pre-op gets documented as far as medications, your Versed, all the, the ketamine, that kind of stuff. If you have a prosthesis, like a hearing aid or like your glasses, things like that. Typically, we want to let like dentures. We want to let the patient have those as long as possible. And then it's usually just before we put them to sleep, we're going to take those like hearing aids, dentures, glasses, things like that, so that the patient still has kind of the most amount of sensory input that they can get. They, if they got glasses so they can see, where they're going, who they're talking to, things like that. If they have their hearing aids so they can hear. All jewelry needs to come off because it's a electrosurgical hazard, right? That electricity can go to the metal in that jewelry rather than going to the grounding pad and cause burns. And then the patient's chart always follows the patient. So it's there with them in pre-op. It comes with them to the operating room, and it leaves with them to go to PACU. That medical record is always with them because we're always documenting the things that we do for this patient. A lot of the pre-op meds that we give, we're trying to get rid of that anxiety, right? Give kind of a nice smooth induction, right? They don't have the spasms going on, things like that. We're trying to reduce the amount of gastric acid that's being produced so it doesn't come back up. And we're trying to reduce the amount of general anesthetic that we have to use. If the patient's nice and calm already and everything's okay, and I don't really care and everything, they don't have all those stress hormones and things raging around in their body that we have to overcome first with the general anesthesia to keep them under. So, and then we also have the patients fast or don't eat or drink anything at least 8 hours prior to surgery to prevent that aspiration, to prevent fluid or particles or something coming up from the stomach and getting down into the lung, causing like a pneumonia, aspiration pneumonia, is what it's called. But yeah, it's typically 8 hours. It used to be back in the day that they made it no food or drink after midnight the day before your actual surgery. But what if your surgery was at not scheduled until 3 o'clock in the afternoon? So now you've gone 15 hours without eating or drinking anything. Could cause other problems along the lines of like a dehydration, and you could be extremely irritable. And then when you come in, because if your case is booked that late in the day, more often than not, your case isn't going to start on time because things just kind of happen, right? Life is life. So now you're hungry, you're thirsty, you got a headache, right? You didn't get to have your morning coffee, you're just irritable. And now any little thing that happens, and you're just going to be much more. And then now your stress hormones are all elevated, much harder in terms of general anesthesia and things like that. It just makes it worse all around. So now it's at least 8 hours prior to surgery, no food or drink. They also do the physiological monitoring, right? These are our vital signs. We're checking oxygenation with the pulse ox, right? And ventilation, right? There's the bellows. For those who remember like Bugs Bunny cartoons, that was when he took the big brown heart shape, looked like accordion thing with a nozzle in it. He'd stick it in like Elmer Fudd's mouth and pump it up, and then Elmer Fudd would inflate and fly away like a little balloon or something. That's that bellows on the anesthesia machine. They're watching that rise and fall. You're also watching the little green bag inflate and deflate. And now it doesn't like completely deflate and completely in, but you can see it kind of fluctuate, right? They're watching the cardiac function. That's the EKG, right? They're checking body temperature. That can either be the strip on the forehead or those Foley temperature. They have a temp probe inside the Foley catheter, and they've got that hooked up so they can actually get a numerical reading on their anesthesia machine for what the body temperature is. Very important to watch because if that starts to rise uncontrollably, you start to suspect malignant hyperthermia. and you get the crash cart and you immediately inject dantrolene. You're watching for neuromuscular response, right? Partially to know, is the patient starting to wake up? But one of the very first signs of malignant hyperthermia is muscle rigidity. So everything like clenches up. Usually the anesthesiologist is going to hear a complaint from the surgeon first, saying, it feels like the patient's like really tightening. Are they relaxed? And then now the conversation begins, like, what? And then now the anesthesiologist is looking down at the patient and checking the jaw muscle and see if that's clenched, right? If that is clenched, they could be pinching and biting down on their tube. Now they don't have oxygen coming in either. And then they're watching for that the fluid balances, fluid and electrolyte, right? This is where they're looking to see how much blood they've lost during surgery, things like that, so that they can replace how much fluid has come out on the Foley versus how much fluid we've given, right? Especially if you've given a diuretic like a mannitol or furosemide or something like that. Furosemide, the other name for furosemide is Lasix. Or like a Lasix or a mannitol. Now you're definitely watching your fluid because you could be taking the electrolyte balance off. So they may have to kind of work with that too and monitor that. Ventilation, oxygen perfusion. Pulse ox is mainly the way that they're monitoring this. But then you have, you're also watching the patient. You're making sure that the lips are still like nice and blue, things like that. With capnography, that is where you're monitoring the amount of CO2 that's coming off during ventilation. The SARA is the Smart Alarm Respiratory Analysis. So it'll go off when it detects too high of CO2 levels coming off. There may be something metabolically going on with the patient where you're producing a lot of CO2 in the system. And they may have to give certain drugs and everything to kind of counteract those. The arterial blood gases, now you're getting an actual reading of hemoglobin and everything from arterial blood. They'll actually draw that blood. That blood has to be put on ice and taken over to like the respiratory therapy department, or they can come pick it up too. But they have a special machine over there, and it'll come back and tell you, how much oxygen in the blood, how much CO2 is in the blood, what's the pH. There's a few other things, but then they can get a real good gauge of how well that patient is doing, right? Are the tissues being perfused, or are they just compensating, things like that? And what are some medical interventions that they can do to help that, to help correct maybe a pH imbalance or something like that. Fluid electrolyte balance, right? They're checking that blood loss. They're giving back IV fluids and plasma if they need to, and blood. They can even do like an IV infusion pump where they don't have to really, the pump takes care of it for them. They just set it. I'd say give this much, give 125 cc's of whatever's in this bag in an hour or something like that. And then so now they know what to look for out of the Foley bag. This is the place where you really get into that hypo isotonic solutions, understanding how all that works. But then they're checking that circulatory function, right? The EKG, blood pressures. You can even do transesophageal monitoring, where you put a probe down the esophagus, down near where it makes the junction with the stomach, because just to the left of that is the heart. And you can do kind of like ultrasounds or have like a little probe there that's actually monitoring the heart through the esophagus. You can have, like pumps and monitors inside the vascular system monitoring the heart, like the pulmonary artery catheters and things like that. You're checking pressures, making sure that and that those things are doing what they're supposed to be doing. Um, those are typically going to be done more in like open heart surgeries, where you're going to be doing that. These kind of transesophageal monitorings, pulmonary artery catheters, those kind of things are mainly for like the open heart. So the anesthesiologists who do open hearts now have to get trained in a little bit more equipment and techniques and procedures and things like that. So we're checking renal function, right? Part of this is in the lab, right? We're looking at the BUN, how much nitrogen is in the blood, right? Too much, there could be, another problem going on. Body temperatures, right? We all know our normal temperatures ranges between 97, 99.5. Some of the temperatures I've taken on people in the lobby, the thermometer has you reading, lower than the 97. But we need to try and maintain that normal thermia because a patient who's too cold isn't going to heal well, and a patient who's too hot isn't going to heal well. We need to keep them in this range. This is where we'll use like those bear huggers, blankets, things like that to kind of help keep that body temperature within a nice range. So now that's not something else now that the body has to do in conjunction with healing from the surgery, is get you back up to a normal temperature, and then it can start doing the things it needs to do for healing. Hypothermia, we can do this purposely to treat the malignant hyperthermia. Right, we're definitely going to give dantrolene to reverse the effects of that succinylcholine, but we can also stack a bunch of ice around the patient, trying to cool them down, bring that temperature down. Right? So the neurological response, this is kind of that level of consciousness thing. We can using those neuromuscular blocks and things like that, we get that relaxation of muscle and things like that because we took out the nerve. We blocked the nerve, so now we can't tell the muscle, hey, contract, and that's where you get that relaxation from. And then your level of consciousness, this is going to help get rid of that intra-op awareness, right? Some patients have reported, being completely awake and knowing and kind of feeling everything, even though everything on the monitor and everything about that patient and just looking at them suggests that they're completely unconscious. It just could be like a genetic factor that particular drug doesn't work that way on that patient. It works physiologically by knocking out all the muscle and all that kind of stuff, but it doesn't work on the consciousness of the mind to knock it out. So that's not it's rare, but I'm sure it's extremely frightening for these patients. So general anesthesia. Under general anesthesia, you're going to have the absence of pain, any kind of sensory perception, touch, sight, hearing, smell, all gone. You won't have any cognitive ability. You're not thinking, right? No memory. And then some of your autonomic reflexes are gone too with general anesthesia. But you're going to be using those muscle relaxants, those secretion inhibitors, and sometimes using those two kind of together. They refer to that as balanced anesthesia. And then the inhalants are used for that maintenance, right? Because you got different phases of the general anesthesia. You have the induction, the maintenance, emergence, and recovery. I'm sure we'll get into those in a few slides. but this balanced anesthesia type system, that's the anesthesia machine, right? Or anesthesia workstation. It has a way to collect wasted gas that's in those soda limes, right? It's that those little white rocks, and as it absorbs this wasted out gas, the CO2 and stuff, and the used up inhalants and everything as the patient breathes out, those rocks will start to turn purple. And then once it reaches a certain level, then you know you need to change out because it's absorbing all of that wasted gas. You're going to have some, gas cylinders on the back. You'll have oxygen, probably some nitrous oxide, and room air most often. You'll have some way to, give the oxygen to the patient, right? That's those tubings that's hooked up in the oxygen mask. Those tubings and masks get replaced, and so does that bag, that little squeeze bag. Those get replaced every procedure. Those all get taken off and thrown in the trash, and then new ones put on. And then that's that oxygen face mask, right? And then you have airways. So you can have like an ET tube, right? That's considered an airway. There's other airways. There are these like kind of hard plastic. They look almost like kind of like a little hook. But those are meant after the patient wakes up, you put those in, and that keeps their tongue from going in the back. And then it's also hollow down the middle of it to allow that passage of air, help keep the airway open while the patient is still kind of groggy and waking up. Types of airways. Endotracheal tube, you have a laryngeal mask, also known as an LMA. What it is it, on one end it looks like the ET tube, and on the other end it's like this big plastic like balloon thing. What that does is it just covers over the back of your throat, and then the tube coming out of the mouth still. That the oropharyngeal airway, and the oropharyngeal one is that hard plastic one they put in the mouth to keep the tongue from falling back, the one that's kind of like hooked. And then you have a nasopharyngeal airway that they put into the nose. It looks like a trumpet. It's just a long tube, and then on the end, it's kind of like a little bigger end, so it doesn't fall down into the nose. But they put those in the nose, and it goes down the back of the throat. The oral airway and the nasopharyngeal airway, very irritating to the patient because we're putting these things in just as they're waking up. And how many times do you wake up and have something shoved in your nose or something shoved in your mouth? Next to never. So you're kind of like, you're trying to get rid of them. You're trying to like spit out the oral one. You're trying to reach up and grab and itch at your nose and play with it and stuff like that. And we're having like, no, don't scratch your face. Hang on, you're just waking up. You're okay. No, you need to leave that in. That kind of stuff. Here's some endotracheal tubes, right? You guys have seen these. You can have ones that are cuffed. That's what this means when it has the balloon on it. And then you have ones that are uncuffed. There is no balloon. And you ask, how do those stay in? They get taped on the outside of the patient's face. These get taped as well, just as a precaution. But the tape is the only way that uncuffed one is staying in. Here's an LMA. Here's that tube, and here's that this is that mask. If you think about the oxygen mask that goes over your face out here, this is just like a mask that's going to cover this back part of your airway. But you are still receiving general anesthesia with an LMA. It's just a little easier to intubate the patient. You got non-occlusive masks, ones that only, they don't cover over the nose. They just kind of do like a halfway, or they stick out a little bit, and they're delivering oxygen to that patient and helping them kind of breathe and wake up. And then you can also do the nasal cannula. It's got the two prongs that go in the nose, and then you wrap like the hose around the ears, and then connect it to the oxygen that way. Typically, this is going to be done post-op, over in PACU, just to kind of give you some oxygen as you're waking up and things like that. But can also be used for patients who are having like local anesthesia or like a regional block or something like that, just to kind of make sure that they're getting good oxygenation while they're in the operating room. But there's that nasal cannula here, and there's your mask for O2. Intubation. So this is us giving, general anesthesia. We're putting a tube down the patient's throat. We want to put that tube in as quickly following induction. Induction is giving those medications to knock them out, right? We've given them some propofol, they fell asleep. We gave them the succinylcholine or the rocuronium to completely relax all their muscles and things like that. And now we need to get that tube in because they're not breathing on their own right now. We need to get that tube in so that the machine can breathe for them. And then you're going to use that laryngoscope. We are going to do this in lab. You guys will perform the Selleck's maneuver, aka cricoid pressure, and you'll get to see all the kind of the steps of this, the use of the laryngoscope and that kind of thing. Difficult airways, right? This could be somebody with like no neck, severely, morbidly obese, or like a lot of tissue, have a previous like a spinal fusion to their neck, to the cervical vertebrae. So you can't really bend that, tilt that head and things like that. Always evaluated prior to surgery by the anesthesia care provider, right? That's part of those questions. They're having you open your mouth, things like that. They're evaluating you to see how difficult, and then assigning that ASA based on how difficult you are. You may have to, do a little pushing on the outside of the neck to help get things into view. You may have to do what's called a burp procedure, where it's a kind of upward like pressure. I haven't really had to deal with the burp. Most of the ones that I've seen is either having to do with like laryngoscopy type method, where the patient's going to be awake. You're going to put a tiny scope into their airway and then feed the endotracheal tube over that scope, so then you can kind of see where you're going. But also they also have now special laryngoscope blades that have a little monitor associated with them. So now you can actually see on video, and people around you can now see too, and direct you more of where you need to put that endotracheal tube. But then you also can do cricoid pressure. That's what CP is, or it's also called Selleck's maneuver. And this is where you're actually going to put pressure on the trachea, pushing it straight down. The anesthesiologist or CRNA, anesthesia care provider, whoever's intubating the patient, they're looking through the laryngoscope blade, and what they're trying to see is the vocal cords, because that's where that tube is going to go. Well, sometimes with patients' anatomy and things like that, the vocal cords are out of view, they can't see it, and you need to just push on the neck a little bit posteriorly. You're going to push down, and that kind of pushes all that those tissues and the vocal cords into view, and then now they can put the endotracheal tube in and get it in the right place. Also, you're going to do this same maneuver, the Selleck's maneuver or cricoid pressure, whenever you're doing something called a rapid induction, or like a trauma patient or something, like somebody hasn't been NPO for the 8 hours, right? Because now they could have something in their stomach. So you want that cricoid pressure also helps block any stomach contents from coming back up the esophagus and getting into the lungs while you're intubating. Here's our phases of general anesthesia, right? Pre-induction, that's all that pre-op interview stuff, talking with them, assessing their airway, all that. The induction, giving the drugs to first knock you out, and then getting that in, getting you intubated, getting the tube in. Maintenance, this is what's happening during surgery, right? This is the inhalation gases are keeping you asleep. They're maintaining the general anesthesia. Emergence is when now you're waking up. We're extubating you, taking the tube out. You're now starting to wake up, and then recovery happens over in the PACU, where you're now regaining your consciousness. You're awake. You're kind of getting your memory things back, and the things that you don't remember because of the amnesia type drugs and stuff like that. Uh, Asking, and this is also the time in recovery that the patient is going to ask the same question probably 1,500 times. They'll be sitting there. They'll kind of wake up and be like, "I'm all done." The nurse will be like, "Yep, all done." "Oh wow, that was fast." And then about 5 minutes later, the patient kind of nodded back off. They wake up. "I'm all done," and they just keep doing that over and over again until they kind of fully kind of come back and are with it. Right? They keep kind of like knocking out and waking back up and thinking that that's the first time they've woken up. So the disassociative, right, and subconscious sedation. Dissociative anesthesia, that's that ketamine. Like I said, typically used in pediatric surgery. It's a rapid metabolism. So they give it to you, and by the time they put you to sleep, the ketamine's already worn off. Some of the disadvantages to ketamine, though, are that kind of that dissociativeness, because the patient is they're still in there. They're still conscious of everything that's going on. They just can't do anything. And that may cause a little bit of fear and anxiety and things kind of ramping up a little bit of the stress hormone and stuff inside of a patient. So then conscious sedation, there's three kind of levels to it. You can give them like minimal, where they're just kind of like, usually minimal sedation, you have another kind of anesthesia going on, like a local anesthesia or something like that. You're doing a procedure that's not going to take very long, maybe like a carpal tunnel. You're taking, like a nodule or something off a hand or something small, right? And it's not anywhere near like the main trunk of the body. Moderate sedations, now we're looking at, maybe like like an endovascular procedure, things like that. Deep sedation, these are where at some point during the surgery, you may be asking the patient some questions and everything, but you don't want them moving around a whole lot. You want them out. They're like asleep. So you're going to give them a lot more, a bigger dose of propofol to keep them knocked out. Your regionals, right? Topical, your nerve blocks, spinal, right? Regional just means it's got to knock out an area or a region of the body. So like a topical, you could rub some, best example of this, there is a lidocaine gel that they use in urology that numbs the inside of the urethra so that you're not getting all that irritant and stuff like with instruments going in and out of the urethra, and then the urethra having to be dilated and things like that. It can kind of take away some of that pain and discomfort sensation. But that's also going to be in conjunction typically with general anesthesia, because you don't want that patient moving around while they're up in the stirrups and stuff like that. Local, right? That could just be in that area where you've injected. It's considered a regional because you are taking care of that area. A nerve block, now you're going after a big bundle of nerves that's going to affect everything below that. Right? And I use my arm as an example. You take out the brachial plexus, and now you can work on any part of that arm you want to, and the patient not feel it. And then spinals, you're taking, like the lower part of the abdomen and down the legs for like a spinal or an epidural, or even a caudal block. Caudal block is just a little bit lower, around I think L4, L5 is where they'll go in with the needle, and that's just taking out all those branches that come off of the end of your spinal cord. So it's basically trying to just knock out the legs. But with these regional anesthesias, drug dosaging is a big play in here. You want to, dose it right, because too much, and then that area is going to be knocked out for too long. Too little, and it'll come back. The sensation will come back when you're working. So, and then there's monitor anesthesia care. This is where they're going to give you that propofol. They'll have you on some O2. But instead of giving you an inhalant to kind of keep you down, they're just going to keep kind of with that propofol. And they may give you a little bit more Versed here and there. And basically, they're giving you kind of like the induction meds, but not in such doses as that you're going to be completely out of it. And the one thing they definitely won't give you is the succinylcholine. Succinylcholine and general anesthesia go together. You cannot intubate a patient without completely relaxing their muscles first, because then the gag reflex and everything is going to kick in. They're going to try and the tongue's going to react and try and kick out that tube and stuff like that. But usually during these regional anesthesia, this is when you're doing that monitored anesthesia care, or MAC, giving them a little bit of propofol, kind of that way they're not just wide awake listening to like all the conversations that are going on and hearing on the monitors, and hearing the instruments and the things that the surgeon is asking for and all that stuff. It gives them a little bit more comfort because they don't have to deal with any of that. They're asleep. So, during these regionals and MACs and stuff, it does not have to be an anesthesiologist in the room. It doesn't even have to be a CRNA. It can be just a regular registered nurse from the OR that's had like an in-service or some training on monitored anesthesia care. Our role in terms of this anesthesia administration kind of thing is we're verifying the supplies that we have. Right? We have a syringe and a needle. Do we have the right syringe? Right? Do we have the right needle that the surgeon wants? And when filling your syringes, you want to make sure you fill it right to the line. You don't go over the line. You don't go under the say you wanted to fill a 10 cc syringe. You fill that plunger right to 10. You don't bring it over 10, and now you don't know how much you have in there because it's not graduated past that. This way we can keep track of how much has been given. We're getting the drug poured onto our field, and we're verifying that drug, right? 1% lidocaine with epinephrine expires July of 2022, right? We're labeling all of our containers, whether it be the syringe or the cup, whatever it's in, right? We've got typically on your field, if you're doing something under local anesthesia, then you want to have 2 hypos and 2 syringes. That way, whenever they've used up one syringe, they don't have to wait for you to refill it and get the bubbles out of it and then give it back to them. You can have the other one already ready. So then you just hand them the one that's already full while you fill the other one and get it ready to go in case they need more after that. And then you always want to keep track of how much has been used. That's something that you're going to have to report to the nurse at the end of the procedure. That she'll ask you how much local was used, 12 cc's, 14, whatever. That's all used to keep track of how much pain medication has been given to the patient. So when they're in recovery, if they're experiencing more pain, then they know how much more they can give them before they've reached max dosage. On the nerve blocks, typically, if we're not scrubbed in, we can be helping, kind of like hold the extremity that needs to be held, help, like for the beer block, help it apply the tourniquet or supply the anesthesiologist with an esh mark bandage that you're going to wrap around that extremity. The esh mark is like this stretchy kind of plastic material that you're going to wrap it from distal to proximal. So from the fingertips towards the tourniquet. And what that does is it does a process called exsanguination. Exsanguination is you're removing the blood from that area. So by squeezing it, you're squeezing the blood back down the arm and back to the main trunk of the body. And then once you've done that, then you inflate the tourniquet. And now there's no blood or very little blood in that extremity. So as you start to inject your locals and things like that, then now it's only the local that is traveling in those blood vessels rather than blood. During like a spinal or an epidural, we may need to prep the patient. Most often, though, what we're going to be doing is helping hold that patient in the position that they need to be in. The patient can either be like on their side, kind of in the fetal position with their knees kind of up on their chest to kind of push and give a good C shape to their spine, because that's going to open up those spaces in between the vertebrae and the spinous processes so they can fit their needle in. Or the patient will be sitting up with their feet dangling off the edge of the bed and doing that same thing. We're just there to make sure that they don't fall, right? And to help kind of hold them in that scared cat position, right? There's with the patient on their side doing a spinal anesthesia, and you can see it kind of opens that space so you can fit that needle in. But if you're doing a spinal, that needle is right up against the spinal cord, and you're injecting the fluid right around the actual spinal cord. If you're doing an epidural, you're not actually puncturing through the dura. You're just injecting it on the outside of the dura, and then it'll absorb through and then get onto the spinal cord that way. Yeah, we talked about that. Anesthesia emergencies, right? This could be drug toxicity. We've given too much of the drug. We've gone over the max dose, and now it's starting to damage tissue. Or the patient could be having some kind of an allergic response. If the patient is already intubated and the patient is having an allergic response where their airway is swelling and things like that, that tube stays in. Because if you remove that tube, you may never get that airway back. Cardiovascular toxicity. This is where you may have too many electrolytes or too much other particulate in the blood, and now it's too thick, so it's causing an issue with the heart. You could have a heart attack. Laryngospasms that lead to like an airway emergency, because now it's opening and closing and opening and closing. You can't get a tube in there, and it may start to spasm where it's closed and it's just kind of shaking, and it never really opens enough to get oxygen and things in. And then anaphylactic, the most severe of allergic reactions. Patient could go into shock from losing too much blood. That's circulatory shock. Cardiogenic, something happens with the heart when they're having their anaphylactic reaction. They go into an anaphylactic shock. Septic shock from like an infection that they have, right? Malignant hyperthermia, hemorrhage, right? The patient's bleeding out. Those are anesthesia emergencies because it's affecting heart rate and blood pressure. And those are two of the things that they're monitoring, right? Hemolytic reactions. This comes from blood transfusions. If you say the patient lost a lot of blood, they were going into like a circulatory shock, you want to replace that and you're giving them blood products back, but you didn't do your check. You didn't do the 2-person check because you were in a hurry, and the blood types didn't match. And now the new blood is coming in, the patient's body is seeing that as a foreign object and it's attacking it and destroying those red blood cells. That's a hemolytic reaction. The number one thing to do in a hemolytic reaction for a blood transfusion, the very first thing that you have to do is stop the transfusion. Stop giving them that foreign blood. And then a deep vein thrombosis, also known as a DVT, usually happens in the calf muscle, but that's where you'll have a clot formation. That is an anesthesia emergency because that can now move and become an embolus and get to the heart or to the lungs and kill the patient. So that's when we'll use like those thrombolytic agents and things like that to try and break up those thrombi or thromboses. Thrombi, I think, is the actual plural of thrombus. But that's kind of anesthesia. We'll do some practice on vital signs. We're definitely going to do the Selleck's maneuver, cricoid pressure. You'll be able to see like the process of intubation and things like that. The other thing I do want to address is Monday is not your midterm. My apologies for being out last week. I'm still waiting on some word back on some of the tests and things that I've done to find out what's going on. But I should be back on Monday. We are going to push your midterm to Wednesday at 1:30. Or I'm sorry, at 1, from 1 to 2:30. It'll still be the same number of questions, but that'll give us a chance on Monday to talk about what you need to study for on that test. But this has been Chapter 13, Anesthesia. I'll be sending these out to you guys shortly.